starting. So Sue is going to talk to us about positive birth experience for long-term benefit, the right care, the right time, and the right relationships. Thanks a million, Sue.
Thanks, Joan. I've got a little sign here. It says you cannot share screen while the other participant is sharing. So I don't know whether that's gone away or not. I'll just try.
Can you try again now, Sue?
Yeah, okay, that looks like that's working. So yeah, I'm really sorry I can't be there with you, and I absolutely understand that people are catching up. I think so. I'm now hearing that, is that right? I need to finish by 10 to 10. Is that right?
10 is fine, Sue. 10 is fine.
10's okay. Okay.
It's just that 10 to 10 the president will be arriving, so she'll be hearing the last bit of your lecture. So no, don't worry.
Oh, okay, that's fine. Right, let me just find my presentation again. So I'll cut it down a little bit then, but not quite so much. So of course I had the presentation right ready there, and now it isn't. So let me just track it down through another route. I'm assuming I'm sharing my screen now. Yeah, can everybody see my screen? Just checking. Let me know if you can't, because I'm assuming you can.
Yes, you can. Yes, we can see your emails.
Yes, in my emails. Yeah.
And now, yes.
How many hundreds of thousands of emails we have. Right, so I'll skip through the first bit relatively quickly. So I'm just putting it onto full screen here.
Yes, it's very visible.
So what I was going to do was just to summarize what I said when I gave a presentation in this kind of similar area at the beginning of the COST action. So it's really, as with all these COST actions, really phenomenal to find ourselves at this point, isn't it? With all the work that's been achieved in this particular one, which has been amazing. So I'll just go very quickly through this, because this was what I already said a few years ago, just to demonstrate where we're at, really, what's happened and what hasn't happened in the interim. So the business of overdiagnosis is an issue around the world, not just for maternity care, but also for general areas of healthcare. And again, I presented this idea of overdiagnosis and the negative consequences of it in 2020. So we're still dealing with that now, I think, aren't we? And this is a more recent example than the one I gave before, which is Peristat Europe. And you can, I don't know how clearly you can see your countries down here. What you can definitely see is the difference between cesarean section rates in orange and instrumental birth in blue around the world. And as before, Cyprus is massively larger rates than many other countries, and other countries like Sweden, much lower rates. And the perinatal mortality rates don't necessarily align with these differences in cesarean section. That is, high cesarean section rates don't necessarily align with. Can I hear some chat in the back? Can you hear me? Okay. I can hear somebody talking. Can you hear me? You can? Okay, that's fine. Yeah. So a difference, low cesarean section rates don't necessarily sometimes correlate with low perinatal mortality rates, and vice versa. Not always, but sometimes. And last time we also went over, and I know that the action has been dealing with this as well, with epigenetic consequences. And this is a study that I talked about last time, where there was a comparison between elective cesarean section and vaginally born infants and the outcomes in terms of the epigenetic phenomena that were manifest. And I know that various people have been looking at the notion of both epigenetics and the microbiome over the last 4 years, which has been brilliant. This was a conclusion from that particular study in 2014. And what's fascinating is there's been so little evidence since. Very few people are engaging with this topic. There was a big flurry around 2015 or so, up to 2000, and not much since. So it's still a wide open field for analysis. In this particular study, they found phenomena that did seem to be correlated with the empirical finding that type 1 diabetes in under 5-year-olds seem to be increased with elective cesarean section from a very low base. Obviously the incidence is very low, but an increase of about 20%. And this particular study seemed to explain why that might be from an epigenetic perspective. And it also found that women who had shorter labours had the babies seemed to have similar epigenetic changes or lack of changes to those who had elective cesarean section, suggesting that labour does something important. And again, I don't think it'll be a surprise to people that there's a whole range of autoimmune phenomena that have been linked to mode of birth, and maybe specifically to physiological birth. That is, not having physiological birth seems to have some kind of relationship with these phenomena, although some studies dispute this finding. So it's still a very wide open area, as I've said. And then we also last time did actually look at what happened with induction of labour, and again there is some evidence from animal studies, again not really repeated recently, indicated that perhaps induction of labour might have some similar effects, and therefore suggesting that physiological labour and birth is the important aspect, not necessarily electives, the other modes of birth. Subsequent to the presentation last time, we have published a paper that actually looked at what happened following induction of healthy women with no risk factors in the children up to the age of 16 years. And I think for me, one of the most interesting findings was higher rates of admission to hospital for infections up to the age of 16 years in babies that had been induced for no obvious medical reason in healthy women, when you control for all the other kind of factors that might get in the way of that. Again, this is not saying that induction should never be done. It's not saying cesarean should never be done for individuals, because on an individual level, it matters very often, whether that's by choice or by need, but it's saying that at a population level, we may be risking an increase, we may be running at risk of an increased risk of public health issues in the longer term if we don't support physiological labour and birth where that's wanted and needed and possible. Moving to the microbiome, this is data from the longitudinal TEDdy study showing a difference in in bacterioids in babies born by cesarean section versus vaginal birth. And again, I don't think this will be a surprise. What they did actually find, though, in this particular study published in Nature, was that the largest effect in terms of different bacterial colonization in the baby's gut was to do with breastfeeding. So the combination of mode of birth and breastfeeding seems to be really important here as well. The other study, which I think we did talk about last time, was this very interesting one. I know you can't read all the detail here because I'm going to go through it quickly, but basically what it found is it comparing babies born at home with those born in hospital, spontaneous onset, no antibiotics, no water birth, basically everything completely the same in hospital and home. There was a difference in colonization of particular bacteria, positive bacteria in the babies born at home versus hospital. So again, there seems to be something about the environment that the mother and the baby is kind of used to or grows up in or developed in, whatever, that seems to be make a difference to what happens to mother and baby during labour and birth. I'm not going to go through these ones in detail, as I say, because I think you know about it. I'm just going to flip through them. But this notion of positive pregnancy, labour, birth, postnatal experience. So although it's important to look at trauma, and this action has done a lot of very, very important work around trauma, we have to keep in mind that, again, the positive experience really matters to mothers and babies. And this is far more than just satisfaction. This is delight, elation, positive changes that really at the minute within many maternity health systems, we are completely forgetting. So this was the data from the original study in this field, which was around positive pregnancy experience done for WHO, looking at these things as being important and hypothesizing that this relates to Maslow's hierarchy of needs, where actually we're just focusing on safety and physiological needs, and we're forgetting all this other stuff that actually really matters in terms of mothers and babies and families and birthing people and society into the longer term. This is the intrapartum data, giving birth to a healthy baby, clinically, psychologically safe environment, emotional support from competent, reassuring, kind staff. Physiological birth, though the need to go with the flow was acknowledged, and many women, were happy to have interventions if they needed or wanted it, as long as they were kept in the loop about what was happening and had a hand in the decision making. And there's been a subsequent review by I think members of this action, summarizing this notion of what a positive childbirth experience is. So her experience of interactions and events that make her feel supported, in control, safe, respected. And it's about being joyful, confident, and accomplished with longer term positive impact. So more than just what happens during the labour and birth itself. And then subsequently, we published another review about the postnatal period, reinforcing what's been done before, basically. So adaptation to self-identity, competence as mother, changes in their circumstances, so being able to adapt and be resilient to changes in their circumstances, being able to navigate ordinary physical and emotional challenges. And this relates to the critique of over-diagnosis of ordinary challenging psychological experiences as trauma. And I'm sure this has been, and I know this has been debated within this action, that we shouldn't over-diagnose ordinary emotional roller coasters and ups and downs as trauma. And many women actually report some parts of their birth as being traumatic, while also reporting their birth as being a positive experience. And sometimes, you know, facing one's demons and dealing with things that are really difficult can actually result in a really positive sense of self-achievement. So we have to make sure that we don't you know, factor that out in our studies when we only focus on the particular components that women in birth find or report as being difficult, and then interpreting that as fundamentally traumatic. And experience the dynamic achievement of personal growth as they adjust to the new normal of motherhood in their own cultural context. So these reviews altogether look at this whole continuum from the beginning to the end. And many women don't conceptualize it as different. They see the whole thing as a psychological continuum, resulting in hopefully that positive outcome. But we don't really measure this. So the study that was published by one of our PhD students, Gillian McKelvin, recently basically could find very little evidence of the literature concerning positive experiences, and most variables are still pathogenic. Now we need to get beyond that, so beyond the too little, too late, too much, too soon, into something which actually is much more balanced. So turning to the UK context, because you know, Joan particularly asked me to look at this because there are some quite interesting and difficult challenges in the UK at the minute. So the vision of the Better Births government policy, and again, I don't expect you to read all this, but the vision is for services to be kinder, more personalised, more family friendly, with more information, where women can access support, delivering care which is women-centred, and in high-performing teams with basically competent and caring staff. That's what we're supposed to be doing. I mean, and that's been our policy in the UK for a number of years now. But what's actually happening in the UK is our caesarean section rates are going up quite dramatically compared to the rest of the world. So the colours here from this particular study in bold show the dark green is the red is the UK. This is the change in the UK, and the green is England going up here, and this blue is the average non-UK countries here. So you can see that, you know, from 2014 onwards, our caesarean section rates in the UK are rising very dramatically compared to those in Europe, whereas the rest of Europe is either laterally equalising, stabilising, or decreasing in many cases. And that's a really interesting phenomenon. And this is another graph or graphic figure from the same paper showing the correlation between perinatal mortality and caesarean section. So here you can see Norway and Finland, low caesarean section rate, low perinatal mortality rate. France, relatively median caesarean section rate, but high perinatal mortality. And then here, a kind of bunch of countries, including the GB, very high and very high rates of caesarean section, and not necessarily low rates of perinatal mortality. So this whole question arises about what is going on here. Recently, we set up a network of maternity service researchers, mostly midwives, in the northwest of England, and the group in that meeting, who were clinical midwives who were interested in research, reported that all these things are now happening in the UK, which is a reversal from what was happening before. This is going backwards. So VE without fully informed consent, no interpreters present, lithotomy for spontaneous birth, membrane sweep, no consent, no eating and drinking in labour, no mobilising, enforced pushing. I can't read that one because actually it's off my screen. Let's just have a look. Yeah, induction. So lots of things happening without consent, but also lots of phenomena, lots of practices happening that, you know, we have known for almost 40 years we should not be doing, and yet we are going back to doing them. Why is this? There are toxic environments, and a number of you will have known about the various reviews that have been going on in the UK that have found a whole load of problems. This is the most recent one. So I won't read this first. Well, I will read this first quote, actually. I work in this particular place. I'm ashamed to say I feel intimidated at work. I'm made to feel stupid. I feel completely unsupported by senior staff. I dread going to work with certain people. Management are not approachable. There's a blame culture. Slog your guts out. It's okay if your face fits. We operate one rule for one another for everybody else. At times, it's an awful place to be. So what I think has changed from the conversation that was happening 4 years ago, when I was talking about why we're not able to do positive labour and birth, or why we should, is a focus on how staff are feeling and what's happening to staff and the kinds of negativity that are surrounding staff, not just in the UK, but elsewhere, but specifically, I think in the UK at the moment, this is really problematic. And part of it is to do with the social media conversation that's happening. This is a recent headline from one of our papers in the UK, widely read papers. And when it talks about quack remedies being peddled by NHS midwives and the obsession with natural birth, it's talking about aromatherapy and massage and those kinds of, if you like, complementary therapies, which women love, which midwives have been providing for a long time, for which there's no particular evidence of harm, even if there's no particular evidence of benefit. And basically what it's saying is we should not be using or offering any of these remedies for women. They should really basically be having epidurals and, you know, and those kinds of things, and not these kinds of things. So this is just typical of the kind of dialogue that's going on in the social media. This is one that Joan asked me to talk about specifically. So this was our conference on normal birth, which we were heavily criticised for a number of reasons. This is the International Normal Labour and Birth Research Conference, which has been going since 2001. And we were heavily criticised on social media and in one particular newspaper, but it previously had been in a whole range of newspapers for other events we've been doing, where we had asked Bill Kirkup, who was the author of a critical report into maternity services, to come and talk to us about what was a problem, you know, and why normal physiological labour and birth might be a problem. And he was pressured into pulling out of that conference because a group of people who had lost their babies, very sadly lost their babies and been treated badly, thought he should not be there because we promoted this dangerous ideology of normal physiological labour and birth. And I could talk a lot more about that, but I won't because of the time. So when does normalizing birth as dangerous and traumatic become a normal social mental model, and what are the consequences? So this is just again, I showed this last time, a headline from a US woman saying that normal birth traumatized her. But in this case, this woman was actually induced. So you could argue whether normal labour and birth is actually, or physiological labour and birth is actually what she was talking about. She actually talks about an unmedicated natural birth. And this is her induction of labour. So we're potentially normalizing something which is not actually physiological as physiological, which raises a whole range of issues. So this is looking at maternal experiences of childbirth and postnatal expectations of behaviour. So basically, a subjective experience seemed to matter more so than the actual place and mode of birth. Social support enhanced the experience, and further support, this offers further support for the importance of making childbirth a positive experience, because it actually influenced the way that women felt about their baby's early behaviour and temperament. So it has and again, I don't need to tell anybody in this audience, I don't think, how important labour and birth and the experiences are in terms of future well-being of mothers and babies. This is a kind of relatively recent study on triggers for traumatic birth. And basically, one of the questions in the survey was describe the birth trauma experience and what you found traumatizing. And they did a thematic analysis process. And there were 4 themes: the care provided, disregarding embodied knowledge of women experiencing what they felt to be lies and threats, and violation. The point being that, you know, very often changing the way women feel about their labour and birth experience is in the hands of staff. But if staff are also feeling traumatized, it's really difficult to know how that is going to be operationalized. So it's what we do, not labour and birth itself. Women felt that care providers prioritized their own agendas, resulting in unnecessary intervention. Women became learning resources for staff, and their embodied knowledge was disregarded because of the care providers' clinical assessments. And this is the word, this is from the data. So care providers used lies and threats and coercion related to the well-being of the baby. Women described actions that were abusive and violent, and these triggered memories of sexual assault. So the problem is, relating to what I was saying earlier on, that, you know, what women then describe as traumatic birth then becomes reified into birth as traumatic, whereas in fact it's actually not the birth itself or the labour and birth itself, it's the way that we do labour and birth that actually creates these norms. But unfortunately, if women believe that it's actually birth itself, then the only recourse they have, arguably, is to elective cesarean section, because, you know, otherwise they're exposing themselves to something which ultimately they're going to find traumatic. So we create a scenario in which the only choice women can make is either home birth without attendance, free birthing, or elective cesarean, because otherwise they're going to be exposed. So we did a big review for WHO, looking at all published language and literature in all languages in all of health and social care to find out what actually was underpinning abusive care, if you like, across the piece, recently published. And we found 2 adverse consequences. Firstly, social normalization of violence. This could be sexual, emotional, verbal, whatever, especially for othered groups, and obviously especially for women, or women being one of the other groups that we might be talking about here, but other groups too, in terms of race, sexual orientation, disability, etc. And then, interestingly, the belief that mistreatment is necessary to minimize clinical harm, that actually staff felt they had to do things that they knew were abusive because that was how they would minimize adverse harm for mothers and babies. It was basically in the best interest of mothers and babies. And this seems to be one of the areas that we could really start to unpick within our services. And this seems to result in these kinds of phenomena. So bystander behavior. So if we see things happening that we know to be problematic and harmful for women and babies, we just ignore it because we believe it's in the woman's best interest, or the person is doing it in the best interest. Toxic environments that create people who are difficult to work with, and vice versa. And personal circumstances for the care provider, any of these things. So death of a loved one, divorce, moving. Sometimes we assume that people are behaving the way they do because they're just they are fundamentally abusive, or they're burnt out, or whatever. But it could be that they have a whole load of things going on in their lives that we don't really understand, that we should be trying to understand for them. Miscommunication, and again, we don't really have time to do this exercise, but some people see this picture as a young woman, some see it as an old lady, some can see both, but it's the same picture. And if we're not able to see through the eyes of the other, then we can't communicate well, either with fellow staff, or those we manage, if we manage people, or with the women we care for. The different mental models that people have about what evidence and safety and personalization is. And again, I don't really have time to unpack this, but we do, when I say safety and you say safety, we think we're saying the same thing, but maybe we're not. We have to maybe unpack what we mean by that. Otherwise, we're going to get miscommunication. Anticipation of humiliation and bullying. People in those kinds of toxic environments I just talked to you about, who actually behave as they do because they think otherwise they're going to get bullied or humiliated. So women and birthing people end up being the victims of that because they, in the hierarchical systems. We all know about this: fear of blame and litigation and making mistakes, and just having an empty emotional tank. Just having nothing left in the tank to be able to give to people. The more recent review in the UK actually was making this turn towards the positive, however, and I'm going to try and make a turn towards the positive in my last kind of 15 minutes here. So what they said is, actually, we need to identify poorly performing units. We need to give care with compassion and kindness. We need to respond to challenge with honesty, and we need team working with a common purpose. So the government has accepted these findings. So it would be interesting to see whether we are able to turn the kind of the super tanker of the NHS around towards this way of thinking and behaving. Because actually, if we get this right for staff, it's very likely we're going to get it right for service users as well. And again, coming back to the paper I was telling you about the disrespect and abuse, and why it happens in health and social care that we just published, we were interested in the various theories underpinning this at all levels. So culture, policies, community, interpersonal, individual, but acknowledging that each of these levels is made up of human beings, individuals, people. So although we talk about the system is us, and we have to get it right for us. And the theory of planned behavior kind of explains that a bit. And I'm quite keen on this theory, as those who know me will know, although I know that psychologists have criticized it. But I think whenever I've looked at this, it seems to be true that we are guided by 3 beliefs. Basically, will I get any benefit if I do this thing? Whether I'm a manager, whether I'm a CEO of a company, whether I'm the government minister, all levels of a system, will I get a benefit if I make the differences that are being asked for here? What's everybody else doing around me? Because I want to do what everybody else does. And basically, is it easy for me to do it? And it seems to me that if we make changes at all levels of a system that make it beneficial, normal practice, and easy for individuals to behave in ways that are going to make a difference, then we're going to make that difference. And I'm going to just talk a little bit for 10 minutes about what those things might be. So one of them might be moving from power over, an asymmetrical relationship, towards power to, where the actor themselves, the person themselves, can carry out certain outcomes, and then power with, the ability of a group to act together about collective goals. And it might well be that some of the research we might do to close the evidence practice gap might be about moving from power over to power to. So, doing these things here to actually create a change at a cultural level, at a kind of organizational level. And I don't know if any of you have ever seen Ted Lasso. It's a TV series, but if you haven't, I would recommend it, because there's some brilliant lessons in Ted Lasso about how you might move from this power over towards power to. This is, again, I know you can't read this, but this is a program undertaken in Monash in Australia during COVID, because they realized that obstetricians and gynecologists were very burnt out. And so they put in place a kindness program to make sure that their staff were optimized, their staff well-being was optimized. And if we look at some of the recent data on the psychobiological impact of kindness and compassion, we can see why it's important. So, positive interpersonal connection, decreased mortality are markers of better health in general. We're not just talking maternity here. And actually simply seeing kindness and caring activates the neuropsychology of kindness, which is a really fascinating thing, not just doing it, but seeing it done. So, as a role model, doing kindness and compassion can actually change the psychobiology of people around you. This particular study was around a pediatric dental clinic where people were parents were randomized, were attending into, while they were waiting, watching either normal children's programs or some positive videos, quite small numbers. And they found the ones who watched the kindness media, the positive videos, had a significant increase in feeling inspired, moved, touched, happy, calmer, more grateful, and less irritated. Just watching, while they were waiting, these kindness videos, they seemed to be more optimistic and less anxious. And all those who were involved in the study were offered an honorarium and given the opportunity to give the money to charity or to keep it. And those who watched the kindness videos, 85% donated to charity versus 54% of those who just watched the standard. This is a very dramatic influence. I'm going to just skip this slide. Well, no, I'm not. I'm just going to go to the next one to look at the kinds of neurohormonal impacts. So of social support, and I'm equating social support with kindness and care here, but that's a big equation, but still lower catecholamine levels, a reduction in immune-mediated inflammatory processes and cytokine production, impact on natural killer cell activity, so protection from infection and recovery quicker, opioids and oxytocin, increase in opioids and oxytocin production. So obviously very relevant for maternity care. So in my final 10 minutes, this is a really rapid run through all of this. So, my apologies if it's been difficult to keep up, but you can look at the slides afterwards, obviously, because I think we'll have access to them. So I want to talk about how we make this happen then at a systems level. And I want to talk about the potential for safety 2 thinking. And some of you may have heard about this. So safety 1, safety 2. This theory, and again, I know you can't read the text here particularly as it is at the minute, but is around unintended consequences and opportunity costs. So the idea that actually safety 1 thinking, the current thinking that we operate in this extremely risk-averse society that we live in, where the kind of avoidance of anticipated regret is such a big part of our mental models, and which is so influential in those kinds of negative environments that I was talking to you about beforehand. Basically, what this slide illustrates is that safety 1 focuses here on the things that go wrong, which are a very small percentage of the overall amount of things that we do within healthcare. So the vast majority of the time things go right, this part of the normal distribution curve, but we focus here. And the trouble is that what we do is we focus here, we find one thing goes wrong, we have a huge maternity review like we have done in the UK. Okay, there were a series of things that went wrong in those hospitals, but still. We then say, okay, here's a solution. And we apply that solution to the whole of this part of the care that we provide, where in fact things were actually going right. And in applying the solution to the things that go wrong to everywhere else, we actually disrupt what goes right, creating the kinds of problems I've just been talking about, and potentially increasing risk for women and service users and also for staff and also for organizations. And this idea has been taken up by, for example, the Royal College of Obstetrics and Gynecology. So it's not completely off the wall. There's a lot of people that are beginning to engage with this idea, because we keep repeating the same mistakes over and over again by focusing only on safety 1. Safety 1, Safety 2 doesn't say you must forget things that go wrong. That's really, we have to still focus, we have to still make sure that we monitor and adapt to those things, adapt, make changes happen. So we don't create risk in the system, or we don't perpetuate risk in the system, but we also must be aware of the unintended consequences of disrupting what goes right, because that creates more risk in the future. The other important idea to think about in terms of Safety 1, Safety 2 is the notion of work as imagined. That is, what's in the protocols, what's in the guidelines, what's in the rules and regulations, the things that we imagine we're supposed to be doing, and actually work as done, what we actually do every day, flexing, nuancing, adapting to make sure that we can deliver what's required for individual mothers and babies and service users and staff in the minute, which is not necessarily what's workers imagined. It's not necessarily what's in the protocols, guidelines, rules, etc. What works for populations doesn't always work for individuals. And this here, work as done, is what makes things safe and positive where it's allowed to happen, with competent, caring, skilled people who know the guidelines, but can adapt and flex them for individuals on the ground in the messy dynamics of maternity care. And this actually also links with complex adaptive systems models that I think some of you in the action have been working with. And there are examples where this has really worked. So things do not go well because people simply follow the procedures of work as imagined. Things go well because people make sensible adjustments according to the demands of a situation. Work as done. So I'm not going to read this quote. Positive relationships equal the best outcomes for each mother and baby and for the staff working in the services, informed by evidence, but tailored to them, what works for them. And the place to start is with us to make this happen. Compassionate and humble leadership really matters. And if we set the tone and role model, others will follow. That is the end. I do actually have a 3-minute video here. I don't know if I can actually make it work. So we could either show the video, or if there's time, I could take some questions if there are any, or thoughts. And again, my apologies, that was such a quick romp through. So just, should I show the video or take some questions, or just stop? I can't hear anything, so I don't know what the best action is here.
Thanks for fascinating talk. It's a lot to observe. Thank you.
So I'm assuming that means I won't show the video. So if you want to, if you get the slides afterwards and you want to, do have a look at this. It's really fascinating. Or it's really uplifting, actually, not fascinating. It's an uplifting video that's really worth looking at.
Sue, can you hear me now?
Yes. Yes, I can.
So we were wondering if you would try the video, see if it will play, and then we might still be able to get a few questions and do both. Okie
dokie. I'll see. It'll probably play my end. It's just whether it will show your end, I think.
Okay.
Let's see. I might have had to change some settings to make it do that. I think is it coming through your end? It's beginning to load my end.
It looks like it's loading. So we have the lady's image. I think it'll probably play. We just need to check if we've got sound.
Yeah, it might be the sound issue. Let's just see when it's loaded up. It's really about climate change, but it makes the point that each individual can make a difference effectively.
Brilliant.
Okay.
Yeah, constant.
Can you hear that?
Yeah, we can hear it.
Right.
They're being bombarded by problems that we face. And sometimes we can get completely overwhelmed. The story of the hummingbird is about this huge forest being consumed by the fire. All the animals in the forest come out and they are transfixed as they watch the forest burning, and they feel very overwhelmed, very powerless, except this hummingbird. It says, I'm going to do something about the fire. So it flies to the nearest stream, takes a drop of water, and it puts it on the fire and goes up and down, up and down, up and down, as fast as it can. In the meantime, all the other animals, much bigger animals like the elephant with a big trunk could bring much more water. They are standing there helpless and they are saying to the hummingbird, what do you think you can do? You're too little. This fire is too big. Your wings are too little. And you're big, so small. You can only bring a small drop of water at a time. But as they continue to discourage it, it turns to them without wasting any time and tells them, I'm doing the best I can. And that to me is what all of us should do. We should always feel like a hummingbird. I may feel insignificant, but I certainly don't want to be like the animals watching as the planet goes down the drain. I will be a hummingbird. I will do the best I can.
So the metaphor, if you like, and the idea there is that, you know, each of us in our research area might feel, sorry, these are my emails coming in. I should turn that sound off. Might feel that we can't do very much. So our little research project isn't going to get it very far, but each of us doing our research project to try and turn this tide towards a more positive kind of way of doing maternity, a kinder, more compassionate way of doing maternity care has an influence in the longer run as we all build together to a program of work that hopefully will have an impact on the ground. And of course, those of us who are clinical practitioners can be doing that, you know, in our everyday work as well. So, you know, if we can all work together as managers, practitioners, funders, you know, funding research that works in this way, and then translating it through implementation science into something that actually does make a change happen. And, you know, complexity theory would argue that eventually there'll be a tipping point if enough of us do that. So we can actually turn that supertank around really quickly so that we don't have this trauma and we do have far more women, the vast majority, and babies and birthing people and families and societies moving towards this kind of positive space that's generated by really good pregnancy, birth and postnatal experiences. So any questions if we have time? Thank you, everybody, for listening. Oops, sorry, I'll stop that. Trying to escape.
Sorry, Sue, we're just changing microphones. Maria Healy has a question.
Hi, Sue. Thanks so much. As always, a really inspirational, upbeat, you know, evidenced, up-to-date evidence you're presenting is fabulous. Thank you. Just a couple of comments, really, as you're most likely aware, and I've spoken to you before about the guidelines for admission to midwifery-led units in Northern Ireland, that they were pulled after, you know, an unfortunate incident. And all of a sudden, as you said, you know, one instant in relation to the graft, you said right at the very, very beginning, and then and it was working so well, those guidelines, and translated into different languages, and all of a sudden, the whole aspect has turned around completely. Guidelines pulled, home birth guidelines pulled, and we've now a review, a midwifery review now, which to an extent is great, and there's really fantastic chairperson there. So yeah, exactly. You're just saying that. I don't know what's going to come out of it, but hopefully it'll make a difference. Continue to go back and have a look and see if we can continue to implement these for women. I really want to also make a comment about the video that you showed about making a small difference. And I had showed this to some student midwives 4 years ago. It's a really impactful video. And 1 week after showing the video, one student came in with a tattoo of a hummingbird in her arm. And one week later, another student came in with a tattoo of a hummingbird in her arm. So it's really uplifting. Thanks so much again.
You're very welcome. Sheena introduced me to the video, so I can't take credit.
So we can't hear you now. Have you got, probably because of your emails, your speaker's off, is it?
No.
No?
But we can see you.
Huh? I think you're muted, Sue, from your end. No?
Say something.
Hello. No.
Oh,
Yeah.
No.
Okay.
You know, I was just gonna say thank you very much, Maria, and yeah, I mean, hopefully that review will work out well for you all. And yes, I can't take credit for the video. Sheena Byram introduced me to it, so yeah, and I think hopefully they had the tattoo and then they went away and they did the hummingbird thing, and that will make all the difference. Yeah.
Sue, can I just ask a question? Things are changing in Ireland from the legal point of view, and there's now going to be a legal framework around open disclosure, which clinicians are terrified of, because open disclosure has been focused on, I tell you about the mistake I made because otherwise you wouldn't have known I made it. But it's still not around, as you would be saying, the sort of the safety to model. So how do we try and combine both? So the open disclosure, the reviews that have a more positive focus or a more constructive focus on context, rather than just identifying the error and maybe putting another procedure in place to potentially protect it in the future.
Yeah, it's a really good point, a really good question. I mean, I guess it depends on, you know, anybody who has the ear of whoever thinking about that socio-ecological model, you know, all the way from the top to the bottom. I think anybody identifying the individuals who have the power at each level of that model to make a change is the trick to this, because very often there's one or two individuals at each level, one or two government people, maybe a civil servant who actually have, or a civil servant who has the ear of a minister, who actually are the person that can make the difference. They are the one that can make things easy, normal, and beneficial. And it's really important to just keep our antennae open, I think, to find out who it is that actually could have a conversation, or, you know, talk to somebody in a coffee shop or whatever, and change their mind, so that they, as the powerful people, can then actually make that, you know, infiltrate that into the conversation that's going on. And you know, I increasingly, as I say, I think we must stop talking about the system, because it becomes something completely immovable. We have to think about the individuals in the system who are actually the ones who are going to make that change happen at that system level. Talk to them. I mean, I'm sure you know them, Joan, whoever they are.
Exactly. Yeah, so that's amazing. Thank you. We're just going to close this session now and invite Her Excellency, the previous President of Malta, to come and speak to us. So Sue, thanks very much on behalf of all of us. Lovely to see you.
Have a great session. I'm really sorry not to be there. You know, it's been a fantastic action. So congratulations to everybody. And to you, Joan, specifically. Yeah.